Nungri Nungri, everybody. Nanawa Menchi Paul Worley, Napi Puteri Maori Pomerakong, Manajeri Rui. It's great to see you. Today I'm here on Manajeri country in Murray Bridge, otherwise known as Pomeroy. And it's important to be continuing the heritage of telling stories on this country, which has been going on for 60,000 years. Today we hear a story about invention and innovation in South Australia, and something that is often a bit hidden under a bushel when we hear about the opportunity for great improvements in cancer therapy. We sometimes don't realise that those great improvements are a result of research that's actually happening here in South Australia. Today we've got the opportunity to hear from one team at SAHMRI that are doing just that. They're looking to see how we can advance therapies for people who are struck by that awful announcement from their doctor. I'm sorry, you've got cancer. And it seems to be often taken as a death sentence with the approaches that are developed here in our state. They can bring some hope. Professor Dan Thomas is leading a team that's looking at that. The race grand rounds are an opportunity for us to learn from the best in the world and to see how we can apply what they are doing in our region, how we can collaborate in further research, and how we can learn together. So I welcome Dan and look forward to all those things happening today. Welcome, Dan.
Thanks, Paul. I think you guys can hear me okay, and I have a number of patients in the Riverland and Murray Bridge, and I love serving those regional areas. I'll try not to make this too deeply scientific, but just cut to the more important things that's useful for you, for all of you guys. I obviously practice as a clinical hematologist, but we have an active research programming at SAHMRI on level 5. Probably one of our greatest achievements recently is building actual humanized models where we can create a human bone marrow on the back of a mouse and able to engraft a number of cancer samples that no one else has been able to do in the world, which has been really exciting. I mainly do the myeloid cancers because they have a number of recurring mutations, and we're slowly building therapies for each of the particular mutations in these cancers. And these are also seen in solid tumours as well. You can see the ones we're working on there in green and red. Many of your patients, if they ever get cancer, will be asked or invited, or through the PRISM or MOST project, may actually get the tumour to have next generation sequencing, and that produces a comprehensive report and often gives us clues as what are the key drivers that are producing the cancer. And there's so much we are learning about those reports, and I would really encourage your patients, if possible, ask them if their report was actually discussed at an MDT or a molecular panel when there were lots of different scientists and experienced clinicians, because there could be clues in that report that could be extremely useful if the patient doesn't respond to first-line chemotherapy, for example. And these are the kind of questions we ask now, and this is still cutting-edge research questions, but are increasingly becoming clinically relevant. So we try and work out, are there any targetable driver mutations in the cancer in the dominant clone? And you can usually work this out from the percentage. If it's above 30%, it's probably in the dominant clone driving that cancer. And also, are there critical mutations in subclones? So sometimes you might have a variant allele frequency of less than 10%, but it's still quite important because it can grow into resistance for other targeted therapies. And you can add up the different numbers of the mutations on that report, and you can work out if it probably evolved in a linear fashion or in a branch fashion? Are there neoepitopes present? These are very exciting when you get a frame shift mutation and the cancer is actually producing a completely different protein to normal, and they're very effective for targeting with antibodies or CAR T cells. We were very interested in looking at synthetic lethal targets. So these are combinations when a cell can't cope with one pathway blocked, when it's already broken another pathway from a mutation. One of the really exciting things from our own work at SAHMRI in the last 3 months is awareness that many patients with underlying bone marrow what's called CHIP mutations actually have autoimmune disease, often large vessel vasculitis or seronegative rheumatoid arthritis. So we're realizing there's a very strong connection between premature cardiovascular disease and some forms of autoimmune disease, and actually having a clonal population present in the bone marrow. This is just the icing on the cake. It's only been discovered in the last few months. Obviously, if there's a strong family history of cancer, then we want to ask, is what we're seeing actually coming from the germline? Is this something that the patient's actually inherited? So cancer mutations, they appear extremely intimidating, but like the Boeing 737 MAX, they actually have hidden vulnerabilities, and a lot of our research time is spent exploiting and finding these vulnerabilities. I just remind you all, you can call our duty hematologist at any time, 08 7074 000. If you've got any questions about blood results or even management questions, we're very happy to help. Things are changing just so quickly at the moment in hematology, and even what we can do with the CBE. Here's a simple example of a case study. A young woman with fatigue after breastfeeding, and you can see she has a high platelet count. She's got a microcytic anemia, a low MCH and MCHC. And one of the new tests we find very useful is this RET here, which is the quantification of hemoglobin within those reticulocytes. So if you ever have a patient with anemia, remember to order a reticulocyte count. It's actually extremely useful. And that RET here will come up automatically. She ended up having iron deficiency anemia, and she had oral iron, and then she had some IV iron polymaltose. And I just remind you the different classes of iron deficiency. So you can see the RET here is quite low in iron deficiency anemia and thalassemia, whereas anemia of chronic disease, you will not see that RET here is low. So it is quite useful in picking up whether this is genuine iron deficiency or not, especially if a patient has other inflammation going on. Just a reminder of how we distinguish thalassemia from iron deficiency and anemia of chronic disease, and hemochromatosis, which will have a high ferritin and a high transferrin saturation. So case study 2, I wanted to show you to introduce an interesting disease that has been neglected for many years. We're running the first targeted therapy trial for this in the whole world, which is incredible. So this is a 79-year-old retired GP and noted to have a high white cell count, low platelet count, but interestingly enough, a raised monocyte count. And that was a clue. This patient actually had chronic myelomonocytic leukemia. So just to go back a bit, one of my colleagues at Stanford, Sid Jaswal, discovered many of the healthy patients actually have clonal hematopoiesis if you look carefully by sequencing in their blood or their bone marrow, but it doesn't really appear until your late 70s and 80s. And it's led by a number of mutations that eventually, over time, can turn into cancers. But we are now finding many patients at this age group, if they've got autoimmune disease or they've previously had chemotherapy, also have CHIP, which stands for clonal hematopoiesis of indeterminate prognosis. What's really fascinating, especially for one of the key genes, TET2 or JAK2, when you have these mutations, even if the clone size is not very high, you have premature cardiovascular disease. And the odds ratio is quite striking. We don't really know why this is, but we're beginning to realize that the monocytes that turn into foam cells in large vessels are particularly angry or aggressive or pro-inflammatory if they have a TET2 mutation. And TET2 is certainly our second most common CHIP mutation we see. I have many patients. Eventually, that TET2 mutation over time appears to evolve into this disease CMML, which is what we've been studying recently. And is often misdiagnosed by clinicians until they eventually see a hematologist, because it's hard to work out if the inflammation in the patient is coming from infection or actually coming from these angry malignant monocytes. And they tend to have a type of classical pro-inflammatory monocyte population. Their monocyte count is above 0.5 or 1 by 10 to the 9. And 60% will have these TET2 mutations. And there's really very poor outcomes at the moment for this disease. We're still finding new monocyte macrophage populations. They're fascinating cells. They all do many different things, and we're realizing they're very powerful for fighting cancer as well. And this is our working model at the moment, that if you have a TET2 CHIP mutation, over time you often gain a double hit, and then if you get a RAS mutation, it can really explode, and you start to get what's called proliferative CMML, and many of these patients will have a high white cell count. So this is the latest phase 3 trial done in Europe, and just you can see it failed miserably. Hydroxyurea versus a demethylating agent, and no improvement, and terrible overall survival of less than 17 months. So we've made human models of this disease. This is a good example when we knock out the TET2 mutation in monocytes, in human monocytes, you get a very strong upregulation of pro-inflammatory cytokines such as interleukin-1 beta and the inflammasome. The other important thing is that this disease actually requires a pro-inflammatory cytokine to create all these monocytes called GM-CSF, quite different from G-CSF that we use in the clinics for cancer patients, and M-CSF, which is more a benign hormone for the regular patrolling phagocytes. And you can see when we block this cytokine with an Australian invention, an antibody therapy, these cells just cannot proliferate. So this is an update on the trial so far. Many of our patients have, you can see, more than one TET2 mutation. We're running this in 5 different centres across Australia. But what's been wonderful is to see durable decreases in the blast count. So we're stopping these patients from developing acute myeloid leukemia with improvements in spleen, hemoglobin, platelet, and many of these nasty subclones that we talked about from the sequencing at the start are actually decreasing and sometimes disappearing. And this is really the first time anyone's seen this in the world, is disappearance of RAS pathway clones in cancer. These are very tough mutations to treat normally. So here's just a pilot comparison historically with our trial data in green compared to for event-free survival versus these historical controls. So already patients are really appreciating being on this trial, and we're extending lives. So my final case study is a 61-year-old lady with a high platelet count, and we did molecular testing on her. You can order this now. It's called a JAK2 common variant, and will cover most of the mutations in ET or myelofibrosis. And this ET and myelofibrosis either have JAK2 or CALR mutations, and there's no known curative therapy. We've developed antibodies against the second most common mutation, CALR, because there's a neoepitope. You can see that here. And the beauty of these antibodies is they stop the cells proliferating and dividing and producing fibrosis, and with absolutely no side effects on the normal cells. So you can see our antibodies are stopping these malignant megakaryocytes from forming colonies, and a decrease from these stem cells taken from myelofibrosis patients with these mutations. And what's wonderful is the antibodies now in our animal models is completely eradicating the disease, and we've humanized both of our best antibodies, and these will be starting phase 1 and 2 trials here in Australia very soon. So I'll open up for questions, but in conclusion, we're learning about CMML as a chronic inflammatory cancer that arises from CHIP mutations, which many people have in older age but don't know about, but responds very well to an Australian invention, and many mutations with myelofibrosis and essential thrombocythemia can also respond to antibody therapy. So I'll leave it there and open up for questions, but it's really exciting to see Australia begin to take the lead for things that have not been done before in the United States.
Ben, thank you so much. While people are thinking of their questions and putting up their hands, can I ask you a question? And so a lot of your work relies on genomic analysis. What's your view of licking the strip, sending it off to the United States or Europe and getting your genome back, and therefore being able to, tell all of these different mutations that may or may not be present? Is that the future that you see before you've got any sign of bone marrow disease? What's your view on that sort of preemptive genomic analysis, given what you're saying about antibody therapies and all of that?
Yeah, I have to confess I'm not a huge fan for a number of reasons. What you're really talking about is germline testing, so genetic testing for anticipating precision medicine. What I've shown you is examples of somatic mutations that have arisen later in the person, and what we're really seeing more, and we do some germline projects here at SAHMRI, is there's such epigenetic diversity in whether that mutation ever penetrates in the organism or in the human. And there are things we still don't understand about why bad genes get turned off and why bad genes get turned on in different people. And the problem with, and until we know more of that, the problem with knowing too much, if it's wrong, and it often is, you're left with this terrible haunting fear for the rest of your life that may never actually have come about. And many of these variants need huge numbers to power whether that SNP actually has an effect size that's clinically relevant or not. And that's why many whole genome association studies have later proven to be wrong when they've looked at larger populations. So I'm not a huge fan of that. You can find out your ancestry if you want to. What I do want to do is cure people once they have really nasty cancer all over their body.
Thank you for that. I think that's really helpful advice. Second question, you rightly pointed out that many of the mutations that you're dealing with, somatic, can actually occur in vivo, if you like. You weren't born with them, they occur. What work is being done to prevent those mutations? So your work is, from what I see, a person has had that somatic mutation, it's causing disease, and you can then halt it in its tracks. Is there work being done to understand how to prevent those mutations from taking hold in a person? I imagine they're occurring all the time, and there must be some mechanism that either works or doesn't work that allows them to sneak through and proliferate. Is there work being done in that field?
There certainly is. For us, one of the biggest breakthroughs in the last 7 years has been the realization that immunotherapy can kill cancer cells. We didn't quite realize how many different cells in our body are actually there, not just to get bacteria, but to kill cancer cells. And many of these mutations will produce subtle shifts that can be detected by NK cells, some of them even by cytotoxic T cells and monocytes. We do know that lowering your mutation rate by avoiding a cigarette smoke and cooking certain nitrogen products that are associated with smoked fish, certain smoked meats. All of these mutation-inducing factors can mitigate, but I think also having a healthy and robust immune system does seem to make a difference in not letting these guys grow out. One of the most important chip mutations that we're recently working on is actually called P53, and that occurs in patients that have been exposed previously and survived chemotherapy. And what we know is that the P53 clones are actually very weak, and you can outcompete them if you don't stress the cells. But if you keep giving people chemo when they don't need it, these clones can actually start to really grow up and later on turn into leukemia. So I'm all for not over prescribing chemo, using as immunotherapy, and trying to get a healthy immune system and less stress for many of these patients.
Yeah, it's amazing how many times the epigenetic capacity through reducing stress, through increasing sleep, through healthy eating and exercise, and those simple things all go to that microscopic level of actually improving your natural killer cells and your cytokine profile. And I guess that is one of the reasons why people with illnesses like diabetes and other autoimmune illnesses perhaps allow more of these cells to proliferate. Is that what you see?
Yeah, that's right. That's right.
Yeah. So my other question is a very practical one. South Australia is a small place. As a clinician, we find a patient who we suspect has a myeloid dysplasia or a malignancy, and we refer them to a hematologist, thinking we've done the right thing. What are the chances that that hematologist is going to be able to access the sort of information and opportunities that you've presented today? Do we have to just refer to one place, or if we refer to a hematologist, they will somehow get to you and your team if that's appropriate? Or do we as primary care clinicians have to take much more responsibility in who and where we refer to?
Yeah, that's a good question, but we have a pretty good network, and many of our complex cases are discussed on Tuesday mornings by a number of doctors in different institutions. People generally get to know who is subspecialising, and if there is trials open, we're really trying to improve links with regional centres and make it easier for regional patients to get onto trial. And having hospitals such as Berry and Murray Bridge, Mount Barker, that are actually allowed to give out some forms of chemotherapy really assists with that as well. Generally, most whoever you refer to, they will quickly know, wow, this patient could benefit from that particular trial, and many of them attend local and national meetings where we discuss all of these things.
Right, that certainly is encouraging to hear. As you know, RACE supports the Australian Teletrials program, ATP, which is all about getting regional patients access to clinical trials. So we hope we can be part of that. Amy, you've got your hand up for a question.
Hello, thank you. Mine was going back, well, Paul just answered my question around the ATP potential to bring some trials to the Riverland. And then the other question was around the mechanisms for more infectious diseases. So we've done a little bit with HIV in Africa, and also I'm assuming with the mechanisms that have been shown in America. Is there any prospect that is one of the major epigenetic components, or is it more non-communicable lifestyle-related diseases?
Yeah, there are some rare infections that can cause cancer. Okay, and I could list about 6, but they're rare. No doubt Hodgkin's disease is caused by an infection, and many T-cell lymphomas. There's a nasty virus you get in Darwin, HTLV. HIV is definitely, and hepatitis C is associated with cancers. What we are realising is for the CMML, that's the first disease I presented on, that low-level bacterial infections do seem to make it more aggressive. And this is all new. But if you look carefully at these monocytes here, these monocytes here are getting stimulated by this thing LPS, and that's actually the bacterial cell wall of E. coli. So you can see lots of little infections possibly could make these monocytes grow out faster, but that's very early days. And it sounds ridiculous, but it's possible some infections are linked to cancer, yes.
Okay, thank you.
Certainly food for thought. I think you've given all of us an opportunity to think of how amazingly complex and beautiful are our bodies, and yet fragile at the same time. And thankfully, cancers have their own fragility, which you've successfully been able to exploit as well on our behalf. So thank you for the work that you're doing. I think we understand the opportunities that now our patients can benefit from more, and certainly in that sort of common space of understanding when the ferritin doesn't seem to line up with the patient's symptoms of ordering a reticulocyte count can help differentiate between inflammation and the ferritin level. That's a really neat little trick. So thank you for some of those insights and for the work that you're doing. And thank you everyone for being part of this grand round, the opportunity to learn more, to think about what we can do for our patients in this region. And as Dan said, there are increasing opportunities for people in our region to be able to access these therapies through clinical trials. So let's make the most of that. Thank you all, and we will see you next month for the next race grand round.